Come to the most interesting portion, that is, I would want to enumerate in my own words the actual resuscitation as I perform. In the meanwhile of managing the most critically injured patient, we receive a phone call at the trauma center describing the history, mechanism of injury, vital signs, and a basic anatomy of the injury, like if it is a head injury, a chest injury, or an extremity injury. From the moment onwards, we recognize that a trauma team as in designating duties to the casualty staff. Most important is to check whether the oxygen is ready, and secondly important is whether we are able to restore 2 IV catheters simultaneously. Blood is collected for grouping, cross matching, and other investigations. Thirdly, monitors and x-rays are kept ready. Patient may be coming directly from the field or is resuscitated from a level 4 or a level 5 community center. In either case, we do need to examine the patients critically. In case there are multiple patients that are the ones with life-threatening and multiple system injuries, they are treated first. This assessment takes around less than half a minute. The priority is set up as the life-threatening, how much it is involved, so the conditions that are most threatening are addressed first. However, this process takes less time and is more effective if carried out in a team. Like as soon as the patient comes, he is shifted to the hospital stretcher, and the main trauma surgeon stands at the head end to begin the resuscitation. He first examines the general level of consciousness and inspection of breathing, and he gets an estimate of the injury around the head. I remember my time in my undergraduate medicine posting where I was told to say one sentence that my patient is conscious, cooperative, and well oriented in time, place, and person. However, in traumatology, a well conversing patient signifies an airway patency. The breathing is assessed first by inspecting any signs of foreign body in the oropharynx or the lower respiratory tract. Every cervical spine by rule needs to be taken unstable unless proven otherwise with further investigations. Thus it needs to be stabilized. Thus if the immobilization needs to be removed, as the assistant needs to keep supporting the neck. If the patient is responding to pain and has an abnormal motor response and uses inappropriate words, he needs to be intubated. A minimum of 2 large bore needles needs to be secured once a patient comes. Other peripheral lines, cut down central lines should be used if necessary in accordance with the skill level of the clinician who is caring for the patient. At the time of IV insertion, blood should be drawn for typing and cross-matching, and a baseline hematological study should be done, including a pregnancy test for all females of a childbearing age group. Blood gases or lactate levels should be obtained to assess the patient and the degree of shock. Aggressive and continued volume resuscitation is not a substitute for definitive control of hemorrhage. Definitive control includes surgery, angioembolization, and pelvic stabilization. Shock associated is also dealt in a similar fashion. Probably if the patient is unresponsive to the initial crystalloid therapy, blood transfusion should be given. Hypothermia is potentially lethal complication in an injured patient, and aggressive measures should be taken to prevent the loss of heat from the body and also restore the temperature to normal. Injured patients can arrive in the emergency department with hypothermia, and it can also develop in some patients who require massive transfusion and crystalloid resuscitation despite aggressive efforts to maintain body heat. The problem is best minimized by early control of hemorrhage. This can require operative intervention or application of an external compression device. Adjunct ECG for dysarrhythmia or probably pulseless electrical activities, that is called commonly PEA, urinary catheters for volume status, and it also reflects renal perfusion. Urethral injuries should be suspected in the presence of one of the either like blood at the meatus, perineal ecchymosis, high riding, or a non-palpable prostrate. Also, gastric catheters to reduce stomach distension should be placed if necessary. Decompression of the stomach actually reduces the chance of aspiration, but it doesn't prevent it entirely. Actual passage of the tube can also induce vomiting, and so for the tube to be effective, it must be positioned properly and be attached to appropriate suctioning and other monitoring such as ventilatory rate, ABG, pulse oximeter, blood pressure, X-rays should be carefully examined. Pulse oximeter in particular does not measure the partial pressure of oxygen. It also does not measure the partial pressure of CO2, which reflects the adequacy of ventilation. Pitfalls include combative patients that can occasionally extubate themselves. They can also occlude their endotracheal tube or deflate the cuff by biting it. Frequent re-evaluation of the airway is necessary. The pulse oximeter sensor should not be placed distal to the blood pressure cuff. Misleading information regarding the hemoglobin saturation and the pulse can be generated when the cuff is inflated and because it occludes the blood flow. In transferring the patient, communication between the referring doctor and the receiving doctor is very essential. For the secondary survey, it does not begin until the primary survey, that is the ABCD, is complete. Resuscitation efforts are underway and normalizing of the vital functions have been demonstrated. In this setting, the conduction of the secondary survey should not interfere with the primary survey, which actually takes the first priority. The secondary survey is from the head to toe, a fast exam of a trauma patient. The potential for missing an injury or the failure to appreciate a significant injury is great. Also, an ample history is a useful mnemonic for this purpose. Like A stands for allergies, M stands for medications that are currently used, P stands for past illnesses or pregnancy, L is for last meal, E stands for events or the environment related to the injury, related to the history. It is important to know what type of injury it is, whether it is a blunt trauma like having a patient beaten up or a car crash, a fall or a penetrating trauma like a stab or a gunshot, or which part is involved in the trauma. During the secondary resuscitation, physical examination following a sequence of head, maxillofacial structures, cervical spine, neck, chest, abdomen, everything needs to be examined. In head, in secondary resuscitation, we need to see the visual acuity, pupillary size, hemorrhage of the conjunctiva or the fundi. Examination of the face should include a palpation of the bony structures in cervical spine and the neck. Patients with maxillofacial or head injuries should be presumed to having an unstable cervical spine injury. That is, example, fracture of the spine or a ligament injury associated. Neck should be immobilized until or unless all the aspects of cervical spine have been adequately studied and an injury has been excluded. The finding of actual arterial injury as an expanding hematoma, an arterial bruit, or an airway compromise injury requiring operative evaluation. Pitfalls including blunt trauma to the neck that can produce an injury in which the clinical signs and symptoms develop late and may not be present during the resuscitation. Initially, in some patients, decubitus ulcers can develop quickly over the sacrum and the other areas from immobilization on the rigid supine spine board and from the cervical collar. Efforts should be made to exclude possibility of spinal injuries and should be initiated as soon as possible or practical, and these devices should be removed also. In chest, open pneumothorax and large flail segments need to be examined. A complete evaluation of the chest requiring palpation of the entire chest cage, including clavicle, ribs and sternum, should be made. Contusions and hematomas of the chest wall should alert the clinician to the possibility of an occult injury. Although auscultatory findings can be difficult to evaluate in a noisy environment, they may be extremely helpful. In addition, cardiac tamponade and tension pneumothorax are suggested by presence of a distended neck vein, or probably veins, although associated hypovolemia or minimizing or eliminating this finding should be done. Pitfalls including progression to acute respiratory insufficiency must be anticipated early, and also it should be supported. It should be instituted actually before the collapse occurs. Children often sustain a significant injury to the intrathoracic intrathoracic structures without evidence of thoracic skeletal trauma. So the high index of suspicion is essential. In abdomen, patients with unexplained hypotension, neurological injury, and impaired sensorium secondary to alcohol or other candidates for peritoneal lavage, abdominal ultrasound, or if hemodynamic findings are normal, CT scan of the abdomen should be done. Fractures of the pelvis or the lower rib cage also can hinder an accurate diagnostic evaluation of the abdomen, because palpating the abdomen can elicit pain from these areas. An AP pelvis examination should be done, X-ray as an adjunct to primary survey and resuscitation, and that can provide a valuable information regarding the presence of pelvic fractures which are potentially associated with significant blood loss. Injury to the retroperitoneal organs may be difficult to identify even with the use of CT scan, for example, including a duodenal or a pancreatic injury. Coming to the musculoskeletal injury, palpation of the bones and examination for tenderness and abnormal movement should be done. Impaired sensation, loss of voluntary muscle contraction, strength can be caused by a nerve injury or ischemia. Pitfalls including blood loss from pelvic fractures that increase the pelvic volume can be difficult to control, and fatal hemorrhage can result. Fractures involving the bones of the hand, wrist and feet are not diagnosed often in a secondary survey performed in an emergency department. Sometimes it is only after the patient has regained consciousness or some major injury has resolved that the pain of the other area, occult area, is noted. Injuries to the soft tissue around the joint, that is the ligament, are diagnosed only after the patient begins to recover. In neurological examination, patient's level of consciousness, pupillary size and response is taken into consideration. The GCS score facilitates the detection of early changes and trends in the neurological status. Also, deterioration in the level of consciousness changes in the neurological examination, as the findings can reflect worsening of the intracranial hemorrhage. Brain and adequacy of ventilation, that is the ABCDE, must be reassessed. The neurosurgeon will decide whether the condition such as the epidural or the subdural hematoma requires evacuation, and whether depressed until the skull fractures need operative intervention. Protection of the spine cord is required at all times until the spinal cord injury is excluded. Early consultation with a spine surgeon or a neurosurgeon or an orthopedic surgeon is necessary if the spine injury is detected. Pitfalls include any increase in intracranial pressure, that is ICP, can be reduced by cerebral perfusion pressure, and it can lead to secondary brain damage. Immobilization of the entire patient using a long spine board, a semi-rigid collar, or other cervical immobilization devices must be maintained until the spine injury can be excluded. High index of suspicion and providing continuous monitoring of the patient's status to avoid missing an injury is important. With respect to certain regions, for example, when we look at the head, like for neck, 3 vital structures. For head, I'll do a CT scan probably. For neck, I would want to do angiogram for the blood vessels, esophagoscopy for esophagus and a tracheal bronchoscopy. For chest in general, X-ray chest. For heart, 2D echo, also for ruling out an aortic injury. For abdominal injury problems and less severe injuries, they also may become quite apparent. Continuous monitoring of vital signs and urinary output is essential. The ABG analysis and cardiac monitoring devices should be used. Pulse oximetry on a critically injured patient and end tidal carbon dioxide, that is EtCO2 monitoring on an intubated patient should be initiated. Underlying medical problems that can create significantly, that can affect the ultimate prognosis of the patient may be evident. The relief of severe pain is an important part of the treatment of trauma patients. Effective analgesia usually requires the administration of opiates and NSAIDs. Transfer may be considered when the patient's treatment needs are exceeding the capability of the receiving institute. These criteria take into account the patient's physiological status, the obvious anatomical injury, mechanism of action, concurrent diseases and other factors that can alter the patient's prognosis. Lastly, in order to perform the task effectively, one team member should assume the leader, being the team leader, and the team leader supervises, checks and directs the assessment. Ideally, he or she may or may not doing the resuscitation themselves. Not necessary the most senior person may be doing, and it should be involving a team leader. Thank you for listening to this talk. Here I conclude my talk, and in case you have any queries or you need to comment or share your own experiences, please feel free in the section below. Thank you.